service. And finally, which is actually the meat and potatoes of my talk, which is about breast imaging. So before I start, I first need to apologize because the latest statistics is actually published a few weeks ago at the end of October, and I only realized the latest data is available a few days ago. So I couldn't have enough time to update everything. So that was the previous latest data in 2022, but just for your information, is actually now the latest data are those from the year 2023. But overall, there isn't much difference in terms of the trend and the significance of breast cancer in Hong Kong. In 2023, now this is 2022 data, female cancer in terms of new case diagnosed a year in Hong Kong. Among all these different cancers, breast cancer remains to be the most common one. And in 2023, the number is more than 5,500. And overall, over the past 3 decades, the number has been really skyrocketing, as you can see. And in the past, in 2022, we are talking about 1 in every 14 ladies in Hong Kong would have a lifetime cumulative cancer risk of developing invasive breast cancer. In 2023, this number has increased further to 1 in 13 ladies. And if we look at the number that includes in situ cancer, DCIS, 原位癌, then the number is actually even higher. And in the past, we have always observed one very important thing, that is, if we look at the age-standardized incident rates of breast cancer in Hong Kong ladies, we can observe that from the age of 35 to 45, this 10 years age interval, the incident rate is actually increasing very dramatically. That is also same for different population, different ethnicity around the world. And also we observe subsequent overall steady but very high age standardized incident rates for almost the rest of the lady's life. So we can see that it's so important that we need to have a screening that starts off around the age of 40 when the overall incidence is increasing, and we need a very consistent screening. We need our ladies to come back consistently throughout actually the rest of their lives in order to catch their cancer, because they remain to be at a high incidence rate even up to, you can see, the age of over 70. So in any case, locally, if you look at the number of female breast cancer, if you look at those who are from the age of 30 to almost the age of 80, the total number of breast cancer cases within these 5 decades of age range actually amounts for more than half of all the female breast cancer diagnosed. So you can see it's so important. We need to have a consistent and lifelong screening almost. And this is the mortality and incident rates. In 2023, the mortality lifetime risk before the age of 75 is now slightly lower in 2023. It's 1 in 105, but that may just be some slight fluctuation. This is our own statistics in BHC, our Breast Health Center. Over the past 14 years, if we look at all the asymptomatic subjects who have attended our screening, which is a total of more than 80,000 ladies, more than 80,000 attendants, among these asymptomatic screening, and by screening, we really mean asymptomatic, those who have no problems at all, they have no issue, they are not worried that they have breast cancer, they just come in for a health check of their breast condition. So, in fact, we noticed that in our entire cohort, we have an overall cancer detection rate in our asymptomatic subject of 0.68%, which in other words is like 6.8 ladies per 1,000 women screened would be detected with breast cancer. If you know about the worldwide statistics, where in other countries where they have population-wide mammography screening, we often don't expect this high number. We often only expect around 0.5% or less, meaning 5 or less per 1,000 women screened for those who are completely asymptomatic. But for us, we are actually a little bit higher. So what we do, well, Hong Kong Breast Cancer Foundation over the past 20 years, we've been advocating universal biannual mammography screening for all ladies of age 40 or above. Of course, right now we still do not have a government-funded or subsidized screening for all. We only have the latest pilot program funded by the government, covering only the very high-risk lady based on their family history or their genetic predisposition. But then we don't have a universal screening. But that is what we've been advocating for based on the statistic that I've just mentioned. And it's also very interesting that yesterday from Professor Tang from Singapore, that she explained about their statistics, their breast cancer new cases in terms of their number, their population number, etc. I'm actually quite amazed because in Singapore, they have really done a very good job. They have their national screening program. They have a total population of around 6 million. In fact, they have only got 2,000 new cases of breast cancer per year. We are having 5,500, and our population is more than 7 million, but we don't have we don't have a population-wide screening. But in Singapore, they are doing extremely well. They have a national screening program for all. So there are really a lot of things for us to catch up. So what we do have our own, that is the Breast Health Center in Kowloon. We have 2 centers. This is the one in Kowloon. It is our own complex, a 2-story building. What we do in our breast health center specifically, we really try to complete the entire cycle from patient education, screening, diagnosis, and subsequent surgeon's input. That is the whole circle that we provide, including, you can see here, this is our breast care nurse. They are actually using the breast dummy to teach our ladies about self-awareness. Our nurse will also perform clinical breast exam or CBE to every ladies coming in for screening. They then receive mammography screening with our 2D and 3D mammogram machine. Many of them would also undergo ultrasound, and if they've been detected with abnormality, our surgeon's input would provide biopsy and provide subsequent treatment plan as well. So that's what we do. Now, so very importantly, we know breast cancer screening is really very much about imaging in its most evidence-based way. So mammography is the really only RCT-proven tool that can reduce breast cancer death. So that is what mammography is like. A lady would be standing, their breast squashed between a compression pedal and an X-ray detector, and will generate an image, what we call the mammogram film, and we can detect silent breast cancer in this way. So some of us will also need to undergo ultrasound because many ladies do have dense breast tissue, and ultrasound can detect some further cancers. So now that is the meat and potato of my talk. We have some recent breast imaging cases that I would like to share with you all. The first case is a lady coming in for BCSPP. It's the Breast Cancer Screening Pilot Program, which is the government-funded screening program for a very high-risk lady. They come in for screening for free. So this lady came in for screening earlier this year in July. This was her first screen. She's completely asymptomatic. We don't need to perform CBE as per the government screening protocol. Very significantly, she has a very strong family history with first-degree relatives having ovarian cancer. That is her first screening mammogram. Because of time, I need to go through faster. So in any case, there are actually bilateral abnormality. This is right breast CC view, left breast CC view, right breast MLO, and left breast MLO. So there is bilateral abnormality detected on this asymptomatic lady. That is the subsequent ultrasound that I performed for her. On the left breast, we can already see the asymmetry on mammogram correspond to this very obvious breast mass. Now, mammogram can sometimes be a bit difficult to read. For this particular lady, if I do not circle out the findings for you, you may only be able to detect this small mass in the right breast, but you may actually completely miss the entire breast tumor in the left breast. But this is not a very, very difficult case, but it demonstrates to you that mammogram needs to be read very carefully and with very specially trained subspecialized breast radiologists, and that's the practice all around the world. But if you look at, because that lady has dense breast tissue, when we perform ultrasound, the breast cancer is actually so much more obvious. So that is why we do also advocate for additional ultrasound supplemental screening in those with dense mammographically dense breast tissue. But that same lady, I actually need to spend a lot of time in order to identify the right breast mass. And if I don't point it out here for you, you will probably completely miss this mass. And this mass corresponded to a very obvious right breast mass here on mammogram. So sometimes that is really the case. That's why mammogram is so important, because there are sometimes masses that are so obvious. I don't have the time to go into all the details, but there are often these lesions that are so obvious on mammogram, we can almost not able to detect it on ultrasound, but it is actually genuinely there. And I can reassure you, if you are not very familiar with breast ultrasound, you would also completely miss this lesion. Luckily, this one is biopsy to be benign, which is also partly expected in an imaging point of view, but it needs to be biopsy in any case, given also this slightly suspicious mammographic finding. And so this lady, ultimately, we can see that her left breast was diagnosed with a completely asymptomatic 2.8 centimeter breast cancer. And her right breast is actually a benign mass that does not require treatment. And the patient is currently under treatment. The second case, another screening case from the same government screening program, also with very high family risk, first-degree relatives, ladies who have breast cancer. And that is her first screening program. The first mammogram screen. Now, it is a very classic case that we can see, and that demonstrates to you how important it is to have mammogram screening. This whole area so well demarcated, it is all because we can really just by mammogram already tell she has at least a very extensive DZIS, no doubt about this imaging. But if this lady declined mammogram, we do sometimes still have ladies who decline mammogram. I can tell you with 100% certainty, if you don't have the mammogram, no one would ever be able to detect her right breast DZIS, which is actually at least 9 centimeter in size. This is the ultrasound that I perform on her directly. Now, given that I have the knowledge that there is huge breast cancer from the mammogram, then I can point out to you that these tiny little echogenic spots are actually the calcification, and they are actually cancer. But I specifically take a normal contralateral breast of the same patient as a comparison for you. This is the completely normal breast on the contralateral side. Well, you can say this could be a similar finding here. This could be another similar finding here, isn't it? So basically, if you only have an ultrasound image without mammogram screening, you would completely miss her cancer. And that, again, shows you why mammogram is so important, so pivotal in breast cancer screening, because it is just so conspicuous and it can be completely missed on ultrasound. And I perform biopsy, and we do specimen radiograph of the tissue cores that I've taken out to confirm that I've actually got the calcification, because we need X-ray to image calcifications. And that's why we need the tissue cores to undergo x-rays in order to confirm that I've taken out the lesion that I need to sample. And she was confirmed to have a very extensive right breast cancer. There are still further areas of right breast suspicious calcification, expected to be a multicentric breast cancer anyway. But even without any other areas of involvement, her extensive stage 0 in situ cancer would require mastectomy anyway. So for the left breast, there are some other suspicious findings that was biopsy to be papilloma and will also undergo excision. She's also had treatment done. And the third case, routine screening in a relatively older lady of 72 years of age, clinical breast exam completely normal, and her prior screen in 2023 is benign. So she is actually quite a consistent lady who consistently come back for our screening program. This is our own in-house screening program, not the government screening program. She is asymptomatic. Now that is her current mammogram. I know it is very hard for you to see in this projection, but it is there. The cancer is there. And I'll highlight it to you. It is over this area in the right breast, in the upper inner quadrant of the right breast, at around 1 o'clock position of the right breast. Now, in these cases where we detect small areas of abnormality which are calcifications, we'll need to perform additional images, which is what we call the magnified view, in order to further identify and assess the morphology of these calcifications to see if we worry they could be genuine cancer. So that is what we do. Sorry that I need to explain slightly more than usual, because I know that there is a wider audience today. We have probably some radiography students from Tsinghua College as well. So, so bear with me for that, for those who are professionals. Anyway, so that is the magnified view. That is what our radiographer do specifically. And in fact, I have to tell you, our own radiographer are very good with the imaging, because these are some things that even surgeons may not know, because if we need to perform a very good quality magnified view on a lateral projection, it's not an easy task at all. In many places or many practices, they are still doing MLO view magnified view, which is in a way even discouraged by some overseas radiological societies, because if you magnify something on an MLO view, you create some uncertainties and you can actually make a lot of overcalls. And these are things that probably only very subspecialized breast radiologists are aware of. But the fact is, if you need to perform a very good quality magnified true medial lateral view, it's much more difficult than a magnified MO view. But most, I can see even in Hong Kong, many centers, they take the easier path instead of the best path. And we and our radiographers are very good. She can take this view very well. And without a doubt, this is very suspicious. Well, based on imaging criteria, I would grade it as bias 4B. But I know it is very suspicious, because apart from the fact that the morphology is suspicious, it was a new finding. That was 2 years interval, her prior BIRAS 2 normal screen, that is her current screen. There is an absolutely new finding, albeit small, but it is just there. Right, that is, it's the normal breast 2 years ago, that corresponding area, and that is the current area where we detect a small breast cancer. Now, this lady, again, I specifically perform ultrasound for her because I'm pretty certain if I let other people, even the best well-trained sonographers, they would not be able to detect it on ultrasound, even if it is detectable. Now, I'm not saying that these tiny calcifications can always be detected on ultrasound, but sometimes we do, albeit very small. Now, for those who are very professional, they may probably know if we see that kind of tiny 5 millimeter tiny group of microcalcification without really very, very tight clustering, it is almost impossible to be biopsied under ultrasound because ultrasound is almost always occult for these cancers. But the fact is, ultrasound technology has been improving, and also with very good eye, you can sometimes detect these on ultrasound. Most of the time for these lesions, that tiny, that limited number of calcification, you ask any specialist who have very extensive experience in breast imaging, they would almost certainly expect this patient would require stereotactic guided biopsy. But because of the previous reasons I've explained, machine quality improving, and if you have good hands, you can sometimes identify these subtle areas of abnormality. But again, the reason why I need to show you this case is that, well, I've taken a very nice image for you. You may think it is so obvious, so easy, but I can tell you, it took me quite some time to get this image, because in real life, if you're scanning in real life, these areas, these tiny areas of shadows, which are normally expected from the Cooper's ligament shadowing, they are often so similar. In fact, in this lady, this one was initially not so obvious as the image that I captured here for you. This shadow is really so much like the other shadow that I've specifically suppressed the other shadow to show you this abnormality. So if you look at the other plane, in the longitudinal plane, it already shows you it is so inconspicuous already. But then I have quite strong suspicion that this could potentially be the same calcifications that I've detected on mammogram. Because why? Because if you compare the mammogram here, what we do as breast radiologists, we need to flip our image mentally. We flip it in our brain. We try to compare it on the images. That is the original CT view mammogram. That is how it is displayed. We flip it mentally. It goes through in your brain, and you turn it into this way because ultrasound is on this kind of direction anyway. So this layer is the pectoralis muscle. This is the rib. So this tiny thing is already very close to the posterior part of the breast. If you compare it on mammogram, they are actually essentially the same image, all right? Always, whatever image, they're reflecting the same thing. It is at the far posterior part of the breast. There are glandular tissue in front, far posterior part of the breast, glandular tissue in front. So and also the area this is the nipple area. It is at the inner part of the right breast. So in my mind, I can tell it is very, very likely that this subtle shadowing is genuine. And what we need to do is we then, no matter what, this thing on ultrasound is suspicious. It needs to be biopsied anyway. But do we just simply biopsy it without doing anything else? No, because now we have the mammogram features with the ultrasound features. We need to establish where we're dealing with one single lesion, or actually there are two lesions, meaning in the same breast, the patient may have two abnormality instead. So how do we establish the correlation between the two imaging modality? Now, we performed the ultrasound guided biopsy. That is the lesion right there. That is my needle going through that tiny bit of lesion left here. Then I need to also place in a marker there inside the subtle shadow. The marker is right there. The marker is right there. Then afterwards, I also need to perform dual confirmation. What is dual confirmation? Because we need to first confirm whether the tissue that I've taken out has got what I want, meaning the calcifications. And how we do that, we need X-ray. And on X-ray, we can see that there are calcifications on my tissue core. So, well, we are halfway through. We really, indeed, from the ultrasound lesion, we've got some calcification. So that is the first confirmation. And what is the dual confirmation? The second confirmation is the marker that I've placed in. This is a 2D screening mammogram. That is the 3D post-clip or post-marker clip mammogram. The marker clip, which is circular here, is directly over these remaining calcifications. So with a dual confirmation, why is that so important? Well, because of time limits, I cannot explain too much. But in any case, sometimes you have actually biopsied the right area. I can confirm that with a marker, but we may not necessarily get the calcification from that area. So that is why in radiology we call that dual confirmation. We need a specimen radiograph to confirm that we've got the calcifications, and we need a marker to place in to confirm that it indeed is the area of abnormality on mammogram. Because sometimes it does happen, sometimes we have biopsied the correct area proven by the marker, but on the tissue X-ray, the tissue core specimen radiograph, we get no calcifications. That can be because of various reasons, technical reason. The technical reason not necessarily related to the one who performed the biopsy, but technical reason because of the various performance of different forms of core biopsy needles. I myself have experience with using maybe at least 5 different forms of fully automatic biopsy needle and several other forms of semi-automatic biopsy needles. I can tell you all these different forms of fully or semi-automatic biopsy needles have totally different performances when they come to real-life biopsy, especially when you're targeting calcification. Probably some needles, they have stronger firing, cutting mechanisms that can get you the calcifications, because on these ultrasound-guided biopsy, we are not talking about a or vacuum-assisted biopsy. The force of you taking out the tissue is really entirely by the needle mechanism, the diving and the diving and the sheathing mechanism to cut through the needle, to cut through the tissue. And some needles are not so good with that. So even if I biopsy the correct area, we might not be able to get the calcification, which is the most important tissue that we need to assess. And that's why we need dual confirmation for this reason. And on the post-marker clip mammogram, demonstrating to you the specific magnified view for us to look at calcification, some of the residual calcifications right there, and also the marker right there. We have got it. We have got both the tissue with calcifications as well as the marker showing, confirming to you we are at the right place. And the reason that nowadays when we have 3D mammogram, we really prefer post-marker clip mammogram to be done on 3D rather than 2D as much as possible. Why? Because for this particular lady, she is slightly easier because we can view it on, in fact, 3 views, CZ, MLO, as well as a magnified lateral view. On all 3 views, we can get the calcification, the lesion target, inside that image. But say, for example, if this calcification is still further posterior, slightly further posterior, we won't be able to see it on CC. We will only be able to see it on MLO. Imagine for yourself, if you're performing a 2D mammogram, not a 3D, we do not have the Z-axis information from the 2D mammogram. Even if on the 2D mammogram, well, I can see the lesion, I can see my marker only on one view, I can never be certain whether my marker is at the correct location because you lack the Z-axis information. But if this lady, the lesion finding is only seen on one view, but then I perform a 3D mammogram, it really doesn't matter because I can scroll through all the 1 mm slices, and when the lesion is at a particular slide, it will show up on only that particular slide. And if a marker is actually at the right location, it will also show up on that slide or one slide ahead or one slide behind. So because we have the depth, the Z-axis information, even on one single view on a 3D mammogram, So that's why we always prefer these post-marker clip mammogram to be done on 3D. And also, this explains to you why 3D mammogram has such an edge over 2D, because there are always lesions that are only single view lesions. There are cancers that are single view only. There are cancers that are small, that even though they are seen on 2 views, they cannot, even if they are included on 2 views, they cannot be seen on 2 views. So that's why 3D has such an edge as compared with 2D, because if, say, for example, there is a cancer which is only seen on 1 view, and if I have a 3D mammogram, first of all, I can see it much more clearly, and second, I can have more information as to where it is exactly inside the breast, and that would help a lot in subsequent management. And unfortunately, because my time's up, so there are several other cases which are actually very good to explain to you the various advantages and performance metrics with regards to 2D and 3D mammogram, but I don't have the time to go through. So I would like to stop there, but so one final word is, most importantly, we really do need a universal screening program in Hong Kong for our ladies. Thank you very much.
Thank you so much, Dr. Joseph Tang, for your very insightful explaining of the situation.